Nigeria and the whole world. So several have died. Okay, through suicide. Sometimes we read it in newspapers. Sometimes people say, "Oh, what's wrong with him? What's wrong with her? Ah, ah, or it's a coward. Why should someone die by suicide?" We have not asked, why did that fellow take his own life? And most of the time, people are suffering from mental disorders that they are just there, no one to talk to. And I tell you something today that I think we can take home. That 2 out of 3 people who will eventually commit suicide will have told someone at least 2 to 3 weeks before committing that suicide. How we handle that information determines whether that fellow will be alive or not. So if you say, Mama Jango, and you are a good Muslim, you are a good Christian, and then the moment, don't be surprised that 2, 3 weeks after you will be called is dead. But if you move fast by telling someone in mental health, Gudegba, Kwasut, UITH, or even the doctor closest to you, this is it. You might save that life. In fact, the chances that you will save that fellow is almost 80-90%. Please take that away from here today. Less than 10%. Do you know that less than 10% of those who need mental health services actually get it? Either because there are no mental health facilities around. Before Budoegba came here, maybe you have to travel down to Ilorin or not take in Ogbomoso or usage. But it's right at your doorstep now. Then how many of us mental health practitioners are in Nigeria? Do you know that the number of psychiatrists in Nigeria is just about 200? I will talk about the Jackpot thing. How many have left? We just struggle. Isa, myself, Salam, Suleiman, Salim. You train. They go. We are not angry that they are going. But each time they go, we start afresh, training people. Some of us should be resting by now, but we can't, right? Because the younger ones need to be trained to replace those who are leaving. Next slide, please. Nigeria is a country with about 36 states and FCT. And you see that our population has been increasing from 79.8 or almost 80 to 140 to about 235 by estimated population by the UN. So the population is increasing. Yet the number of mental health practitioners, though increasing as will show, but not commensurate to the explosion in the population. Now I've said this before, and then that about 20 to 30% of Nigerians also suffer from mental illness, which approximates to 1 in 4, will experience mental disorders in their lifetime. Can you imagine? About 1 in 4 people in Nigeria will have one mental disorder or not. You might say, no, possible, it's not in my family issue. Sometimes there is because you didn't take good look at it. And by the time you know the various things, then you will understand that this thing is around us. Now, depression and anxiety, even in Nigeria, continue to be the commonest. Okay? The median age of about 18 is the standardized suicide rate age in Nigeria. With about the studies, now these studies are not really telling us what it should be because most of the suicide cases that happen are suppressed. They are not reported. We don't have good reporting system for suicide in Nigeria. So most of the one you hear, maybe newspaper, but a lot of died suddenly, died after brief illness. Sometimes there is more to it. So, but even based on that, the studies in Nigeria that we have shows about 8.8, that's about 9 out of 100,000 people have committed suicide. 40% of Nigerians aged 15 to 64 engage in psychoactive substance use. taking drugs, cocaine, lipo, gas cannabis, tramadol, ice, what they call ethanol on the street. That one is common with our young people. Next slide. Now, what has psychiatrists or mental illness, psychiatry or mental illness been like in Nigeria? I'll just look at it as the pre-colonial period on pre-1954 and 1954 to now as the modern era of psychiatry in Nigeria. Before, it's not that we were not treating mental illness in Nigeria. We were. Our fathers or forefathers were doing something. It is whether that something was really effective or not. But in the absence of something that you can do, whatever you do to save life is worth it. If it's better than placebo. Placebo is like better than kasha. So traditional mental health practice has been àwọn bàbá wa ti ń lo ewé asòfẹ́yẹyẹ Lumofia vomitoria, the seed when you crush it, okay, in my village they use it as part of the wares for the masquerade, for the eye gummies. Alright, so it's been right. And when you use ewé asòfẹ́yẹyẹ and crush it, it contains risapine that will lower blood pressure and therefore the patient will be calm. So it's used to take care of psychosis that is aggressive. Okay? But of course there are problems with using them. But that some patients will not come round properly because you have damaged the brain. And it can, not all mental practitioners or what we call herbalists or diviners. Okay? Iléwé ọmọ wà, babaláwo wà, bàbá nífá ká máa rúbọ. So and gbogbo onífá ló mewé, gbogbo eléwé kọ́ ló mọfá. Okay, so all herbalists, all diviners know about herbalism, but not all herbalists know about divination. So, but just to tell you that we were doing some spiritual therapy. Our pastors, our holiness, our fasts. If it happens, my great uncle was Uluode. So when there is a problem, I know people come in the neighborhood from the villages, they come to him, he gives this, give that, just to help. And he was doing something. Spiritism, consulting spirits, we were doing it. Okay, exorcism. And then, even all this happened in Europe and America of today. It's not as if it's peculiar to us. And when you go now and see all these things we are talking about, they even did in the early, what you call the Renaissance days, when science was coming up. There was attempt to use science. For example, this trepanation was done by making holes that believing that spirits that causes mental illness, if they make a hole, the thing will fly out. See, their own is even worse than ours. So people have done a lot of things, including cutting part of the brain, lobotomy, insulin shock, dipping people inside cold water and hot water. So that's water therapy or hydrotherapy. But then, let's come home. When the colonials came, the West African region, they started this. First one, 1820 in Sierra Leone, the first asylum. Remember that time there was no Nigeria. People just move around across West African region until they divided, they sat down somewhere and divided us in 1904. So, and then Calabar was the first one in Nigeria, asylum. And what is it? Asylum. The aim was just to keep people there, custodian, just keep him or her mentally ill, just put them there. It was not really about treatment, it was just keep them safe from the public. That's why they are called asylum or custodian care. But things changed gradually when people saw that, oh, this is not good. You can treat people better. the humane way, with respect. So, see, Yaba Psychiatric Hospital, the one they call Yaba Kwausi, started in 1907 with just 48 patients. And then, since then, we have others like Arrow also came on board, and then we have Uselu, Kaduna, right, UCH, and Sokoto, yes, Kwari, and then you have UIT, and then to Gudeba. I think Gudeba is the youngest, is it? Another one after, good, Etigaburo. So that's it. So now this is the 10th psychiatric hospital in Nigeria. So we have grown, we have moved. So it's good to recognize this past, that we are not stationary. Next slide, please. So, like I said, okay, and then we have transformation of the treatment modality, and establishment of own psychiatric departments in teaching hospitals, all right, and federal medical centers. So we have moved now, but like Dr. Tikpe says, there is still something that we are still battling with, though we have also moved. Stigma is part of it. People don't want to come. Oh, they will see me. I was telling Dr. Sabi that sometimes you have patients say, relatives say, don't you know me? I say, I don't know you. Hey, you mean you don't know me? I say, I don't know. If I come to that your hospital, people will recognize me. And I tell them, hey, just like you have, other people also have their own issues. And to so take care of yourself. Forget about what people will say. So that stigma is still there. I don't want people to know. I don't want people to see me. All right. But when things get bad, people you do not want to see you will see you in a bad way. So why don't you take care when it is still very early? The earlier presentations are made. You see this mental illness is very easy to treat, especially if people come early. We don't admit that people. No, it's only when we don't have a choice that we want to protect the patient from himself or from others. When they come early, we can manage as outpatient and nobody will know. Please, from today, anyone you see, encourage the fellow to come early. And the doctor, Eduapo, could have been called person and sorrow. That's the training. Even if your wife comes to me to talk about, and I see you next day, good morning, sir. I will know here quick. Or then your wife tells you yourself. That is training. So please be encouraged to come forward. Next. It will be unfair if we don't mention some of our heroes past. Some people worked before us. Alright. There are people like Professor Dewi Lambo, Asuni, Anomoye, Oshodi, Jegede. All these people worked in the early part from 1950 something in the pre-colonial period or around the colonial period. And then the second generation people like Olatawura, Odejide, Ahmed, Murake, or Benite, these were people who worked before us. And when we come to Ilorin, there was a man called Oshodi when Kwasut was General Hospital Ilorin in northern region days. Okay, and then Ogunremi, Olayemi, I'm sure you've heard of Yemi Hospital, right? Oyewumi, Professor Abiodun, Professor Adelekam, they taught us, right? And some of us present here, Professor Isa, were also taught by them. Okay. And then one nurse called Mr. Omoshedi. If you look, there's an hospital called Omoshedi Hospital. That is, he was a psychiatric nurse in UIT, one of the early ones, and I think it deserves to be recognized. Mrs. Ajoge, those who trained Mama Ajoge, yes, and then Mr. Bakari, and Rubide. I can't mention all, so I just did this to show that it's not one person, it was a team, nurses, doctors, clinical psychology. Let's go on, please. So now I want to approach the remaining issues to talk about, because when we are talking about past, present, future, I tried so many slides and I saw that we can't talk separately about past, sometimes without about present, and then without future. So I will just take them on under treatment services. What are the services we render under treatment? Our systems services, and then under that systems we talk about funding, mental health act, which is policies, and then we also talk about research. So we're talking about, in short, training, services, training, research. So under treatment services, let's look at our manpower. A total of only 5 psychiatrists around 1963. 5, wow, in the whole country. And these people I mentioned earlier, some of them, right, who came back to Nigeria after training abroad. They came back to render services to this country, right? And then it grew to 25 in 1975, 35 in 1981, and now we're talking about like 200 psychiatrists working in Nigeria, serving 235 million people. Okay, that's about 1.2 million. Was this one psychiatrist taking care of 1.2 million instead of one psychiatrist to 10,000 as recommended by the terrible. That's like we are times 10 short. Some of the ones we trained, they've left. Some of the ones who are here, they are old people. Some of them are in management, like Professor Isa. So, and you will be able to witness that now I still run clinic, world round. Some of my teachers, whom I will not mention, were not doing it at my age, or long before my age. But the work must go on, right? Okay, then there were a lot of people, so they could do other things like administration and so on and so forth. So while we do the younger one with energy, we do the clearing or of the base. Now look at the number of psychiatric hospitals. So it has increased. Now we are saying the 10th mono psychiatric, that is hospitals that are devoted as psychiatric hospitals. We have others in teaching hospitals, right? So if you add all of them, department teaching hospitals and FMCs, they are over 30 now. Last count I think was about 31. So we are doing well. Psychiatric nurses recommended is 1 to 2 nurses, 1 nurse to 2 patients to manage 2 patients. But here, sometimes we have 1 nurse on duty in my place in UITH. Okay, unlike before that we used to have many on duty, especially morning shift. But things have changed. Nurses are also jackpotting too. And then clinical psychologists, we don't have many. In the whole UITH, you have 1 or 2. Here I don't know how many. But then again, social workers, they are also not many. Next slide. Infrastructure. The number of psychiatrists, we've said that, so we won't go there now again. Alright, in terms of public hospitals, they have increased. And I broke it down to specialists. So instead of 9, I'm corrected now that it's 10. Tertiary hospitals, 20 that have psychiatric hospitals. And FMCs, 24. But even out of these 24, not all of them have mental health facilities. Then data center, what we call drug abuse treatment centers. We have about 10 to 12 models, including now our Budekba and Kwasut and then UIT. That's the most beautiful word here. Alright? Okay, thank you. That's my area of sub-specialization. So don't mind me that I'm leaving them, but that's the truth. It's beautiful, is it not? I've been there this morning with ACO. Okay, now. So private psychiatric hospitals. I mentioned 2, Delhi, Rosel, and then Omoship. So we have got, and all over the country now, our colleagues are now coming up to private hospitals. Sorry. Okay, all right, thank you. Equipment, we are also doing fine. ECT machines we now have. We do modified versions now instead of before that we do just unmodified. In which the patient will never know we are doing ECT. Okay, CT scan, MRI. I know some of our hospitals like Maiduguri have CT scan. Some and they also have FMR, magnetic, what we call transmagnetic stimulation. Next slide. Treatment modalities. You know, psychiatry before some of our early ones working in psychiatry were not regarded as doctors because they couldn't prove. Like, you know, my colleague in orthopedics will show you that the bone is broken using X-ray. Me, if my patient does X-ray, you won't see anything. All right. If you do tests, sometimes you won't see anything. That is the thing in psychiatry. So, but even to treat, we didn't have much medication. Patients would just languish in asylums. But from 1952, things changed when they discovered neuroleptics, chlorpromazine, what people know as agatil. And though it was accidental, but since then it revolutionized. We didn't need to keep people in hospital for too long. You can treat people in 2 weeks, 1 week is well. Let me tell you, there is no mental illness. Kódà go wọ́n ja olótóbi, bàbókù, doesn't matter to us. He will be well, Elokole. We will treat that fellow and he will be well. In my career of about 1990 to now, that's 33 years from residency. I don't know how many we've treated and didn't get well. What happens is that people don't follow our advice when the patient is well. Believing that that is the one that worked. Do you know that when our patients are being treated on the ward, people still smoke àwọn oríṣiríṣi. In fact, about a month ago, sir, you will not believe, one of my patients, we entered the ward in the morning and saw big cocoa alamon under the bed in the hospital. He said nobody must touch it because they told him that cocoa will not collect. The cocoa must not touch it. Said to hell with that, get it out of everyone. All right. So when the patient got well, I said, see you now. You now realize what you were doing was just waste instead of concentrating. So make sure you bring your child for people will not come for follow-up. And when they don't take this medication and stop on their own, they relapse. That is young father. That's the problem. Because initially they do not believe is what we are doing just so that it's working. All right. So we have moved from the old medications to new ones. People that will have less side effects. And I don't say she. It's because the fellow is not coming for follow-up for adjustment. When they start buying the medication on their own. No. When you are coming to us to the clinic, as you are coming, before you enter my consultation, I've already seen how you walk. I've already seen how you